for Professor Hisham Wahba for very clearly showing the case of lung cancer screening worldwide as an evidence and also in Egypt. So I will be tackling the same topic, but from the oncological perspective. I'm a clinical oncologist. I do care about what the radiologists do, but at the end of the day, my main ultimate aim as an oncologist is to save those cancer patients, to treat them better, and to have a better survival. This is my success story. I have a better success as an oncologist when my patients are surviving, when they are early diagnosed. These are my disclosures. So let me take you through the journey of lung cancer worldwide and why there is a screening program that is being installed in multiple areas of the world. The issue is that lung cancer is one of the leading causes worldwide in terms of cancer deaths. 1 in every 5 deaths related to cancers is related to lung cancer. It's definitely more common in men because of the smoking habits, and the incidence is rising in multiple countries, and it is causing some economic burden. So why do we need earlier diagnosis? Because we now know that the earlier you detect lung cancer, the better the outcome is. And we know also that the 5-year survival is very variable between different countries. If you have a high socioeconomic country with a better healthcare system, where patients are detected earlier, you have a better outcome in terms of survival. And you can see from these graphs that patients that have a regular screening, the number of early stages, 63% versus 3% for late stage, stage 4, for example, when people go for screening. But those who are detected because they are seen in an emergency department, for example, only 11% have an early stage disease, and more than 50% have a late stage disease. I think you don't need to be an expert to understand that stage 4 lung cancer is not something good. This is a bad prognosis. This is a bad outcome, whatever you do. Although we have newer treatments with better expectations, yet it becomes fatal at some point of the time. And you have to know also that based on the latest staging system, the staging system actually, why do they do staging? T1, T2, T3, N1, N2. Why do they do staging? Well, because it affects sometimes the treatment, but also because every stage has a different outcomes in terms of survival. And you can see that they go in the sub-categorization of the staging as stage 1A1, stage 1A2, and these are different in terms of millimeters. And you can see that survival at 4 years, 6 years, there is a difference. Even with few millimeters, you have a difference in survival. So a patient comes with a 3 millimeter, 5 millimeter nodule detected and seen by CT scan, and then whatever the radiologist, the oncologist, the pulmonologist sees that this is a nodule that's maybe inflammatory, so let's put him on follow-up, re-see him 6 months, maybe 1 year, and this nodule is now 1 centimeter, and you remove it, and you think you did a good job. We removed the nodule in 1 centimeter. This is very good because we don't see it in practice a lot. But 3 millimeters is not 1 centimeter. And if you want to save the patients, we need to go earlier as possible, yet without doing too much investigations and too much intervention for those who don't need it. So what is the story of lung cancer screening? It started very early with sputum cytology and chest X-ray. Multiple investigation and clinical trials were done with more than 30,000 smokers doing annual chest X-ray and sputum cytology versus chest X-ray alone, but no effect on survival. We didn't detect them early enough to affect the survival versus the conventional way. Another study called the PLCO that was looking at multiple cancers at the same time. Again, a very large number of patients recruited for chest X-ray versus usual care. And again, you do not have any effect in mortality because this is the oncology aspect. I want to improve the mortality. You detect more lung cancer, earlier lung cancer cases, but at the end of the day, you don't affect mortality. And this is the outcome. This is the real value you want to achieve. And then in the early 90s, we started to introduce the aspect of low-dose CT in radiology because we want to decrease, we don't want to be causing trouble to the patient. We don't want to induce tumors by giving too much radiation to a large population that will not have lung cancer. So the introduction of low-dose CT has changed this concept. It is non-cancerous with less radiation. And then you started to have small studies that is starting to show that low-dose CT is superior to chest X-ray in terms of detection of these patients. But again, the issue is not earlier detection or not. The issue is going to reduce mortality or not. The first real big trial is the NLST trial in United States, the National Lung Screening Trial, that has recruited populations that were between 55 and 74 years old, having 30-pack year index, so they are heavy smokers. You need to take those high-risk population that smoked were actual smoker or that stopped within the past 15 years. Beyond the 15 years, the risk of developing lung cancer is much decreased. And they compared them to chest X-ray, not compared to doing nothing, which is the actual what we see in most of the population. And you can see that after 6 years, you have a 20% reduction in the risk of lung cancer deaths when you introduce low-dose CT, and a 6.7 reduction in overall deaths, because smokers do die because of other reasons, cardiovascular disease, stroke, and other things. So the American College of Chest Physicians start to introduce, according to the same criteria of the NLST trial, the introduction of lung cancer screening as a national program. In parallel, we had the Nelson trial in the UK, again showing a very similar results, 24% reduction in lung cancer mortality with low-dose CT scan screening at 10 years. So what is the problem? Because if you look at the worldwide recommendation from the policymakers, you will see that they still have debates to do lung cancer screening or not to do lung cancer screening. Is it really cost effective or it's not cost effective? The problem is that we have false positive. Again, Dr. Hisham Wahba showed us that AI sometimes detect wrongly classify lesions as being malignant, but we also as physicians wrongly classify some of these lesions as being malignant. And this leads to stress and anxiety. This is not the biggest issue, but you're going to take a biopsy, do an intervention with potential complications, and get at the end a non-malignant finding. And this wrong or false positive actually is very variable, ranging from 1% in studies up to 30% in other studies. The other thing is overdiagnosis. We have something in oncology that we have been knowing in multiple cancers, like in prostate, in breast, is that we all at some point of the time harbor cancer cells. Everybody has a development cancer cells. The immunity detects those cancer cells and get rid of them. Some of us will have a small cancer. We will live with it. We will die from other causes, and we will never even know that we had a cancer that was still biologically not aggressive, remaining at this site. The immunity is controlling it, and it will not develop into a clinically significant. Screening will detect those patients, and we are going to treat them because we don't know that those are the indolent disease or not. At the end of the day, we are going to overtreat some patients who would not have needed actual treatment. But in lung cancer, this is not the biggest issue because lung cancer is usually an aggressive disease. The other problem is the hard to reach. It's difficult to reach those elderly active smoking population who are already stigmatized. They know they are doing something wrong. They don't want to get screened because they are knowing that they are doing something that is harmful to them and the population around them. Usually they have a lower socioeconomic class. It is one of the risk factors of developing lung cancer, by the way, having a lower education and lower socioeconomic status. And sometimes they have difficulties in going to do low-dose CT. And then when you do low-dose CT, if you have a finding, you need further investigations. It is costly, it needs travel, you need to get vacancy from your job, and it is cumbersome, and it is a problem to maintain a program, because at the end of the day, when you're doing a national program, you need to be cost effective. So at the end of the day, it's not pushing more people to do low-dose CT. Those who get a positive findings need to do further investigations. If you have a highly successful rate of low-dose CT with a very highly successful rate of detection of nodules, but then nothing happens beyond that, then your program is not successful. Your program is actually a failure. So who should we screen? Again, this is another problem. We have those big trials, but this is not the only risk factors. Age, socioeconomic status, ethnicity, family history, occupational diseases, respiratory diseases, smoking history, we calculate the Pakir index. In Egypt, you know that we smoke anything else than actual cigarettes. You have shisha, you have everything else you can smoke, and you cannot calculate the risk with those patients, and it is a big issue in our program, for example. So you have different models to calculate. Those who are very simplified criteria, like we've seen in the MLST and the Nelson criteria, and you have more complex criteria like the Liverpool Lung Project and PLCO model, where we take multiple factors into consideration to classify who are those high risk. I will not even enter with the Asian population, where they found in non-smoker that screening detected a larger number of lung cancer in comparison to the actual smokers. This is another big issue of discussion in all the conferences nowadays. And the second question, how much do we need to screen? Every year? Every 2 years? So the MEL study showed that annual versus biennial there is no statistical difference. The Nelson study shows that 2.5 years is too long, so it's probably between 1 and 2 years. Again, the cost effectiveness is another very difficult thing to calculate. You have data from UK, but again, in Egypt, it's probably easier because the cost of low-dose CT is probably around $5, around 250 pounds. This is the official public price. So again, it is not that big a problem. It is mostly an issue of infrastructure and having enough CTs. So do we meet the criteria for lung cancer screening? So is it a condition that having an important health problem? Yes. The natural history of the condition is understood. Yes, we have a lot of studies on that. There should be a detectable early stage. Yes, we have an early stage we can detect, not like, for example, pancreatic or brain tumors, where you have difference between an early and late stage of diagnosis. Treatment at an early stage has more benefit. Yes, you have shown use that. A suitable test is a non-aggressive test, so low-dose CT is not something aggressive. It is not culturally unacceptable. The test should be acceptable, as we said. The risk of both physical and psychological should be less than the benefit, yes. Where we are making progress is how much the interval should be, 1 or 2 years, for example, and the cost should be balanced against the benefits, and we are making progress worldwide. So the real question is, should we screen for lung cancer or not? This is not the question. The question now, how we need to do this, and how is a big issue, because the big trials I have shown you is trials that have been done in Europe, in United States, in Asia, and we need our own data because our population is different, the smoking habits is different, the occupational hazards is different. We are seeing a lot of populations that are now using personal protective devices in high-risk occupations, and those are patients that are at high risk of developing lung cancer. So it is a burden in the MENA region, and I have seen from the latest one of our latest publication as a policy publication in the MEA region, that we have a high risk of mortality, and our 2 years and 5 years survival is extremely low in comparison to developing countries. So how we can fix that? We need a continuum of care. Again, as I told you, if we do a lot of low-dose CTs, you need to, at the end of the day, those who do the CTs to have a continuum of care. They need to be well diagnosed, and diagnosed is not easy. It means very well equipped intervention radiologists for biopsy, well-equipped pulmonologists and interventional pulmonologists to do endobronchial ultrasound biopsy, well-equipped pathologists to do a ROSE technique and then detect their very fine cytologists to be able to diagnose the patient, and having very well-trained thoracic surgeons to be able to treat those patients. And then we will have different stages at time of diagnosis. We still will have the stage 3 and stage 4 patients, and we need to improve the treatments, the new immunotherapeutics, the new targeted therapies. And the whole idea, this is a whole package. When you detect more early cases, it will cost much less to treat them, and then you will save this money. You're giving chemotherapy to all stage 4, which is now we know that chemotherapy alone is almost useless, better to give nothing. And you will save this money to treat much lower number of stage 4 disease, for which you're going to give the best treatment possible, and this need to be a public health priority. And like the WHO recommendation in cervical cancer, probably you have heard about the 90% of lady girls need to be vaccinated, 70% screened, 90% well treated. These are achievable goals, numbers that we need to achieve, and we need to do the same in lung cancer, for example. So what are the challenges that we face? Delays in diagnosis. Those who do low-dose CT, until they go referral for a tertiary hospital to do further PET CT, to do further biopsies, they are delayed, and we lose them while we are going through the steps of the screening. Lots of follow-up, a lot of those who are asked to do low-dose CT after 6 months, after 1 year, they don't come back. They feel reassured because the initial test was acceptable. The healthcare infrastructure gaps, the radiology authority here in Egypt have done a marvelous job into increasing number of CT scans and fixing the old machines that were not functioning, improving the technicians and improving the radiologist ability to do low-dose CT and to classify those patients in terms of the Langerhans criteria. So again, we have different ways of doing this. Either you have hospitals who decide to do a screening program, so it is an institutional base, or you have national programs. And as you can understand, there are differences between a population-based screening program or an institution-based. You have more governance and control when you do an institution-based. You retain your patient better. But if you want to do a national program, the optimum way is that you have criteria that are similar to everybody. You don't have differences between those who are screened in Alexandria or those who are screened in Aswan, and you have better governance and collection of data to be able to know, because at the end of the day, we may tell you a recommendation after 5 years that lung cancer screening in Egypt is not really useful and we don't need it. But we need those data to say if we need it or we don't. So we need a call to action to the health authorities to prioritize lung cancer screening. We coordinate a lot with the private sectors because they work in terms of awareness. They are also collaborators to a better achievement of the outcomes through being partners in terms of being closer sometimes to certain communities. The academia needs to put the lung cancer screening into their education and research, and the civil society is definitely in Egypt is a very important. You need to understand that in Egypt, civil society and NGOs account about 30% of the healthcare expenditure. This is huge, and it's very well incorporated into our system. So the presidential initiative, to not delay you furthermore, is looking at 4 types of cancer at the same time. It comes after the breast cancer initiative. We are going to check for lung cancer, prostate, cervical, and colon cancer through the test. And our aim is to reduce the mortality through an earlier detection. But to achieve that, we do not do only screening. We do awareness, we do the early detection, we improve the diagnosis, we work on the management of survivorship, we do a lot of work on data management, because every step from the time of the questionnaires that we do for eligibility criteria till the start of treatment and multidisciplinary team is recorded into a digital system to be able to evaluate. We try to work on creating centers of excellence, because if you want, again, to achieve the better survival by screening, it means a better treatment, and we work on training and also on research. So it all starts with the national ID. You can go through the primary healthcare units. We have more than 3,600 in the whole country, or through social media, medical convoys on hotline. You do the electronic questionnaire, and it detects who are the high-risk population. This is the questionnaire. You can do it in about 10 to 15 minutes. And accordingly, if you are selected to have a high risk for lung cancer, as Dr. Hisham has shown you, you go for a smoking cessation if you have a smoking, because some of the studies have shown that maybe the mortality reduction was related to smoking cessation program rather than early detection by itself, and accordingly you go through the pathway. Professor Hisham again has shown you that a lot of countries are shifting from the lung cancer screening to a lung health initiative. Again, not only because those smokers don't like to hear the word of cancer and lung cancer screening, but also because we detect a lot of non-cancer related diseases, COPDs, infectious diseases, cardiac diseases, and I think at the end of the day, reducing the mortality is not only about related to cancer. We do not work in isolated islands. We need to work together. So low-dose CT, when we detect non-malignant condition, we refer them to chest hospitals. And in the chest hospitals, they do a lot of chest X-rays and radiological investigations. We're going to use AI for those opportunistic cases and refer them back to the screening program if they have suspicious nodules. So in terms of architecture, we have a population outreach program for risk triage, then screening, diagnostic workup, multidisciplinary treatment. This is an important focus. Nobody treats a cancer patient alone, and then follow-up and registry creation. And the patient, from the patient perspective, he sees awareness. He sees that he is eligible or not. He consents for the imaging and sampling. And then, according to the result, we have a recall system to confirm the diagnosis. And we are hoping to be able to achieve a KPI of starting treatment within less than 60 days. In Egypt, the actual criteria that will probably change in the near future are having age of 45 years or older, because in our institutional publications, we have seen that the median age is 10 years earlier than in international population, and therefore probably related to our very early exposure to smoking. But we have also, to increase our detection rate, added another risk factor, which is the symptoms, geographical area, or occupational hazard. So hopefully, this is again why working, talking about AI. This is an AI-generated image, but it's not very far from the reality. We're going to introduce 3 mobile units. We have already the CT mobile units, CT scan units, but we are going to introduce 3 new mobile lung health or screening programs that are going to do all the potential tests into a single station to, again, try to reach the population. This is an AI. When I ask Google Gemini to talk about lung health in Egypt, this is the image that he has shown us, which is, again, not very far from the very near reality. Thank you very much.